Next case of relentless case of posterior uveitis by Dr. Neethu Latiff from Giridhara Institute.
Good afternoon all. I'll be presenting a relentless tale of posterior uveitis. Case report: a 55-year-old lady presented to her OPD with complaints of blurred vision in the right eye since a week, similar to episodes of blurred vision in the right eye in the month of March and July 2023. Diagnosed and treated as toxoplasma retinochoroiditis elsewhere, improved with treatment. So in the month of March, she was treated with azithromycin and oral steroid. And in July, she was treated with a course of clindamycin and oral steroid. So when she presented to us, there was a anterior segment inflammation. There was fine KPs and AC cells of 1+. And as you can see in this fundus photo, there was vitritis with wit floaters. And these few yellow discrete lesions in the periphery was noted. And also RP scarring was noted in the periphery and the peripapillary area. OCT was suggestive of cystoid macular edema, and also you can see the stalagmite-like lesions in the vitreoretinal interfaces. FFA, the media was hazy, but we can appreciate the cystoid macular edema. So the pattern recognition here is multifocal peripheral retinitis with CME, query recurrent, differential diagnosis. Could it be a viral retinitis, toxoplasmosis, or masquerade? So we investigated, CMV titers were raised, the CD4 counts were normal, HIV negative. She was started on tablet valganciclovir 900 milligram BD. So after a week, she came to us with a worsening of the lesions, and the macular edema increased, and the stalagmite-like lesions also increased. So we thought, why not it be a acute retinal necrosis? So we changed to tab valsivir and started on a course of oral steroid. Followed up after 2 weeks, the lesions almost completely resolved. And even the macular edema subsided, and the stalagmite lesions also subsided. And she was doing well with this treatment, but her RNFL edema was persisting. So after a few months, she came with a recurrence. There was vitritis, new lesions noted in the infranasal quadrant with CME. So we increased the valsivir to 3 times, deflazacort 36 mg, and repeated the toxo titers, which was also positive for IgG, negative for IgM. There was also very suspicious activity in the peripapillary area. And then we noted that in the next visit, the lesion in the peripapillary area became much more prominent, and OCT through the lesion was suggestive of inner retinal and outer retinal changes. So we thought of revising the diagnosis, considered vitreous tap, stopped steroid, and then planned tap after 2 weeks. On stopping steroid, surprisingly, the peripapillary lesion resolved on its own. So we waited for another week, and then she came up with a flare-up. And at this point, when I see the lesions in the periphery, I felt like it was a peripheral serpiginous-like choroiditis appearance, not sure. So we did the PCR. PCR was positive for CMV, negative for HSV, VZV, and also the histopathology was negative. So oral steroid was started along with valganciclovir. We asked for a neurologist opinion or MRI brain, patient not willing to do now. On restarting treatment, we reviewed her up after 2 weeks. Her BCVA is maintained to 624 N36, and the final follow-up, the lesions were all, regressed. So what are we really dealing with? Is it an infection or a masquerade? Or is she really responding to the antiviral or oral steroids? And what if recurring again? To start antitoxo treatment or intravitreal antiviral or clindamycin, plan a AC tap for real-time PCR, or do we have to exclude TB in this case?
I think it's a very interesting case, Neethu. I feel it is a case of CMV retinitis, CMV retinitis, because nowadays the Sun classification says that ARN, the causes are only HSV, VZV. If it is a CMV, then we should not call it ARN, better to call it CMV. This is the latest guideline says. So let's call it CMV retinitis only. It is means it was presented like a acute retinal necrosis. Only thing, it did not behave like normally we believe that acute retinal necrosis means immediately it will just spread circumferentially on. But CMV is an exception. But if you see the replication type of CMV in contrast to HSV or VZV, CMV is extremely slowly replicating virus.
Okay.
So that's why I think the spread was just like a toxo. It was not like HSV, VZV. HS and VZV by this time I would have become PL negative with antitoxo treatment.
Yes, sir.
So that's one I feel. Second thing is that PCR already has shown that. So this is another pointer. Third pointer is I am little skeptical about that Everdenz's article also. This is a very good article where they have showed that if you see the stalactite lesion then in OCT, then it is it is a indicator of a toxo. But
Yes,
we
sir.
have seen few cases of ocular TB where we have seen this kind of stalactite. I'm in contact with him only, so we are planning to write that up also. So I feel sometimes certain signs are described in literature. We have to keep in mind that these are not pathognomic of particular entity. These are just like laboratory investigations. Sometimes you have to decide on based on our clinical acumen rather than those signs that if we see that stalactite, whatever the picture is, it can be toxo. I think we should come out from that kind of mindset. Second thing is that another important point here is that CMV can occur in immunocompetent patient also. Your question was that whether it is infection and masquerade. Yes, CNV, there are a lot of reports you have also showed, I think, that CNV can be seen in immune-competent patient. So same thing happened with us. This report just got published in IGO now. So the young lady came to me and it looked like a typical CMV retinitis. We have treated with ganciclovir injection and patient responded. Only thing which bothered us was 23-year-old lady, why she got that CMV retinitis. So I just gave her patient was from Gujarat, so I just gave her an idea that you better do a PET scan. You can go back and do the PET scan and come back for that. And patient didn't come back for follow-up. After I think 3 months, I got a call from Mumbai. They told that, so what happened? The patient went there, did a PET scan, and it showed that there was a Hodgkin's lymphoma. So sometimes if there is some underlying malignancy, that can lead to immune suppressions, which may not reveal in your CD4 count and all. So these are the patients where there is a CMV retinitis and you can't explain that there is no immunosuppression. I think it's a good idea to do a PET scan or at least send to oncologist for overall actually evaluation of the patient that whether there is any underlying malignancy is there or not.
Neethu, in this patient, CD4 count was normal and even PCR was also negative for CMV, you know. And
PCR was positive for CMV.
okay. Vitreous PCR was positive.
Yeah, positive for CMV.
And how often you do serum IgG for viral?
No, herpes virus is no point of doing serum evaluation because these are the ubiquitous organism. Even if you do my CMV or HSV may be elevated because it is there. 95% of us are having the viruses inside us. There's no point doing that and treating them based on that serology.
So, do you think it could be a TB? Like
TB will be in my last.
last. Okay. Thank you, sir.